Good afternoon. Welcome to Medicine Grand Rounds. It's actually my pleasure to present the 2024 J. Schuyler Endowed Lecture in Diabetes. This lecture is one of the flagships conferences from the endocrine divisions and recognizes Jay's contribution to the University of Miami and also to diabetes research, in particular, clinical research on type 1 diabetes. Jay has been here for close to 50 years in all the ranks, even as a chief of endocrine. And in fact, he was one of my inpatients attendings when I was a resident here a while ago. And I'm very happy that Dr. Tadej Battelino accepted to deliver this year a Schuyler lecture. And Dr. Battelino is an internationally recognized figure on diabetes research, and in particular, technology in diabetes. So we're very pleased that he accepted the invitation to come and deliver this lecture. And now he will be introduced by our chief resident. Thank you for accepting the invitation.
All right, it is my honor to introduce Professor Battelino. Professor Tadej Battelino completed his medical degree at the University of Ljubljana in 1990 and completed a PhD focusing on glucose metabolism in neonatal endotoxic shock in 1996. He completed his clinical fellowship at Loyola University of Chicago and his postdoctoral fellowship at INSERM in Paris. Professor Battelino is currently consultant and head of the Department of Endocrinology at the University Medical Center Ljubljana, as well as a clinical pharmacologist, chair of pediatrics, and professor of pediatrics at the Faculty of Medicine at the University of Ljubljana. He is a PI on several publicly funded research projects in the field of diabetes, endocrinology, and metabolism, and has authored or co-authored over 370 papers in international peer-reviewed journals. Professor Battelino is also a member of numerous professional associations and served as president for the 35th Annual Congress of the International Society for Pediatric and Adolescent Diabetes. He served on the European Association for the Study of Diabetes Council and is co-organizer of 16 annual meetings of advanced technologies and treatment of diabetes. He will be speaking to us today on the use of continuous glucose monitoring in non-insulin treated diabetes and type 2 diabetes and prediabetes. Please join me in welcoming Professor Battelino.
Dear colleagues, first, thank you very much again for this kind invitation and for your kind introduction. I'd like to share a little bit on how I see why treating glucose and being glucose-centric, which is not perhaps very popular nowadays, is important. Those are my disclosures for you to review. And I would like to propose to you a little bit of a background, why I believe what we do is important, and then perhaps a little bit of evidence. And finally, I'll just touch the time in range management philosophy and how perhaps it may progress soon. So something doesn't go well. And I love to start with this UK Biobank study that showed in 1/3 participants that were genotyped for cardiovascular risk and had a predicted A1C calculated that within the normal range, an A1C of 4.9%, which is lower normal, versus an A1C of 5.8%, which is upper normal, there is a threefold increase in cardiovascular risk, whatever model you want to use, linear, nonlinear, or however you do it, with Mendelian randomization. And with the same study, they showed actually it's a continuum of damage that glucose does. This is people without diabetes, normal glycemic, pre-diabetes, and type 2 diabetes. And this was published in JACC some time ago. And what it tells us is that there is no glucose low enough actually to protect us from the cardiovascular damage. And this, of course, perhaps may resound to the lipid people that you may be more attacked by, saying that the lower your LDL, the better you're off. Of course, there is not known consequence of having very low LDL, whereas glucose does have a lower limit because we tend to get dizzy if we exaggerate. But still, looks like that for the cardiovascular part, there is no lower limit to be safe. So it seems that we should strive for a glucose as low as possible. Just to show you actually this continuum here, if you want, on these curves, it's very clear. So it's a true to 3 to 4 times gradient in between, again, lower normal and the beginning of type 2 diabetes in this particular cohort from UK Biobank. Just a glimpse that same is true in type 1. So it's not a thing that's related to type 2 diabetes, it's a thing that's related to glucose. And the glucose, you know, doesn't know whether the glucose came from type 1 or type 2. Glucose is glucose in the blood. So this is young individuals. This is the direct net study from the United States. Chronic hyperglycemia, only high glucose. And this is important. So not related to any hypos, impairs spatial working memory. And we also show that it's an acute effect as well. So this is a study inside the functional MRI. And we clamped people from normal glycemia to hyperglycemia inside the MRI and demonstrated exactly the same. So impaired spatial working memory, acutely impaired spatial working memory in this young emerging adults with type 1. But then let's move back to type 2 and show that glucose actually is related, and this to me perhaps is even more important. Cardiovascular death, most of us will have to die at some point. And if the death is cardiovascular, you know, it may be acceptable. However, if you are demented for the last 15 years of your life, this may be unpleasant for oneself and particularly for the family or the environment. And this is exactly what diabetes does. So this is cognitive decline in people with type 2 diabetes. And I'll show you several longitudinal studies from different parts of the world telling you the same story. Just for fun, the viscerospatial function, again, is the most impaired, which is interesting because it seems to be most vulnerable to the effects of glucose. This is the Swedish National Diabetes Registry. Please note, the registry, again, is more than 1/3 of a million people. So this is way beyond all trials that you're used to see. And it is 1.8 million people in the control group. So a very robust data set showing that both vascular and non-vascular dementia is related to glucose. And more so, the higher the mean glucose is expressed by A1C, the higher the risk. Again, only an association with high glucose, no associations with hypoglycemia whatsoever. This is a cross-sectional study, CGM with cognitive performance in older adults, or a little bit more modern, more recent if you want. And again, as you can see, time in range, time above range were associated with increased trouble. In this particular case, I don't want you to look into the table, just the only message is only parameters associated with high glucose were related to cognitive impairment. Again, no association with a hypoglycemia, despite the fact that it was evaluated with a CGM, so that all hypoglycemia actually was visible or recorded if you want. This is, again, a UK Biobank. Here you have normal glucose status in 25,000, almost 26,000 people, pre-diabetes in 2,700, and type 2 with a very small part, because this was by definition a healthy population. They did find people with diabetes later on. And here, again, it's the damage, the initial damage is in the subcortical gray matter. And this perhaps is interesting. So it's all subcortical gray matter. And if we go further, then it is reflected in reduced connectivity. And we'll discuss this in a second. So this is perhaps the first time last year in July that this possible association between subcortical gray matter and then connectivity was reported. This is the ARIC study. There was also this part of it was published last year. And here again, you can see the diabetes onset before the age of 60 in this particular calculation of the ARIC data was associated with almost threefold increase in dementia in this particular population. And this is an interesting study. The data, again, is from the United States, and this is mild cognitive impairment in adults. And please note that the difference, so the more you adjust the model for all, for sociodemographic covariates, behavioral factors, medical conditions, physical function, and diabetes therapy, the more significant the association becomes, which is really interesting. And the second important thing is that mild cognitive impairment is already present in prediabetes because the differentiation between the two actually starts prior to the initiation of this study. So it's a very early event. A little bit of elevation actually already causes moderate dementia. And this is the recalculation of the Maastricht study. And here, please know, there were 3,000 people with normal glucose and with a calculated A1C of 5.4%, pre-diabetes with 5.6%, which in our environment is still a normal level, a normal value. We know that glycated hemoglobin is useless for the evaluation of pre-diabetes. And then 860 people with type 2 diabetes, but very well controlled with an A1C of 6.7. And when you look at the thalamic, again, subcortical gray matter, you can see that fasting glucose and 2-hour post-load were highly associated with the damage, with the atrophy of this subcortical gray matter regions, whereas A1C was useless in this evaluation. And they actually developed a theory out of it that I will share with you very soon, as I promised. Here, another study, people with type 2 diabetes from Japan, and they did the same. So severe cerebral white matter lesions were associated with time in range, the higher time in range, the less, time above range, the more time above range, the more, hypercomponent, and high blood glucose index. So all actually, if you want, calculations related to elevation in glucose. Here are the data on your left-hand side. Whereas the losers were all the data associated, so mean glucose, useless, variability because it's related to hypo, as you know, and all hypo variables actually were non-significant in this population. And this is really important because it's different from the things that we were trained in for decades. So these white matter lesions were associated exclusively with indices of hyperglycemia. And this study that's coming from South Korea is interesting because it's done by radiologists. And the question here was, can a radiologist, not knowing anything about the glucose of a person, from the scan, from the MRI, say this person has diabetes or this person doesn't? And they were very successful because they can easily determine who has diabetes and who doesn't based just on the image interpretation. And this is the model that I'm promising you, is they believe that the initial lesion is perhaps down to these small vessels that are important for the subcortical gray matter. And then as a consequence of this damage in the subcortical gray matter, perhaps the connections and the axonal damage that is visible is developed. So the first message I want to give it to you that the elevated glucose is harmful and the even lower level of elevated glucose is harmful. So perhaps to shift from this irrational fear of low glucose to a very rational and well-founded fear of elevated glucose or upper normal glucose. The second thing is, and this is perhaps also an important message, this is super old, so 35 years, I remember it when I just graduated, right? That the early intervention matters, true for death, true for cardiovascular. This is an old study, but we have new data actually showing exactly the same. So this is diabetes and aging study. The sooner you lower the glucose, the better the outcome. So both for micro and macrovascular outcomes. So we have no time to lose. So the usual attitude in type 2 diabetes that, okay, we have a little bit of a glucose there, perhaps is not the best idea. The third thing that I want to share briefly with you is that we in diabetology are a bit slow. If we compare ourselves to oncologists or, okay, not to mention ICU people or cardiologists, it took us actually 35 years to move from a stupid measurement of mean glucose named glycated hemoglobin to a more relevant measurement like continuous visibility of glucose. And even now, not everybody actually is persuaded. And the second is that because of the fear of hypo and because of the, as you say, possibility of litigation in relation to hypoglycemia, we completely neglect hyperglycemia that basically causes all the cardiovascular outcomes and dementia in people. And my question is, how come this is not a question of litigation? I mean, in my environment, in the European Union, it is more likely that somebody would complain, look, doc, I mean, you allowed me to be hyper for years and now I'm demented, as opposed to, oh, I had a hypoglycemia and fell. It's a very big difference. One is easily treatable. It's even preventable nowadays. The other basically is a damage that you can't help. So the suggestion is that we do go from a surrogate marker of mean glucose, which is A1C, to a concept of time in range. Do we have evidence to do so? Well, perhaps the first evidence or the biggest evidence to start in type 2 diabetes with basal-only insulin, so non-intensively treated insulin, is published by the Mobile Group by Rich Bergenstahl and clearly showed the benefit of CGM. And then it's the HypoWeight study, which I like because what they did actually is they checked for the complex, more sick, more comorbid older individuals and less comorbid older individuals. And they showed a difference, whatever metric from the CGM you use. And what's interesting is they showed that the cognitive impairment was related to high glucose during the day, as you can see here in the yellow and orange, and perhaps more hypoglycemia during the night. The thing is that this more hypoglycemia is still well within the consensus range. It was only less than 3%, less than 4% a day total, or a night if you want. So the thing is that very likely it's the high part that's damaging these individuals. And again, just to let you know, when you check, so time below range, if this was the thing that you wanted to see, it was not associated with A1C, and also the dementia was not associated with A1C. So it's a really important message that A1C is useless, actually, if you want a more precise evaluation of diabetes. This is another example. So this is a 12-month single-center randomized controlled trial just published this month. It's coming from the Steno. It's again, it's a MDI, a smaller portion here. Mostly it's one injection of insulin only, and they showed a very considerable benefit exclusively linked to high glucose. So they were successful in improving the time in range for 15% a day with no difference, no increase in time below range. So basically, using CGM improved this non-intensively treated population from the Steno Center in Denmark. So a very clinically relevant improvement in time in range, so in glycemia, without any cost, actually, of hypoglycemia. And I'm sorry, I didn't mention, at the same time, using CGM actually caused a loss in weight. And this is very interesting, and we'll come back to this. This is the initial evaluation of people without diabetes in the mobile study. Not very interesting. It was blinded. It couldn't help people. But they, for the first time, see the differences in different therapies using blinded CGM in individuals without insulin. This is actually a European users from the Libre study, and they had a non-insulin using population in it. And please note, so in the non-insulin group, actually the time in range increased from 50%, which is super low, to 72% at the end of the study, which is within target, if you want, for this non-insulin treated population. And the time above range was the reason, of course, why this happened, and no increase in hypoglycemia in this particular group. This study again comes from South Korea, and it's a lovely study. So this is people actually with type 2 diabetes, and the only intervention they had here was CGM and food management. And a very simple scheme, you may be familiar with this paper, it's a lovely paper. So healthy food in a general sense, this was the question, a yes or no. If yes, no modification needed. If no, you had to cut down the amount. Super easy. And glucose high, yes, cut down, no, that's okay. Please look at the difference in the A1C, just with this simple approach in this early type 2 population. Okay, so A1C, this is the primary outcome, but please note, fasting glucose improved and also body weight decreased. Again, CGM, in addition to manage glucose, actually is a behavioral modification tool. And people observe what a certain food does to them and change their behavior in addition to improve glycemia, lose weight, which may be, of course, of interest. With losing weight, blood pressure also went down. And this is the immediate study published last year. They showed actually a 10% increase in time in range. Very importantly, we'll discuss this more tomorrow for those that are interested in time in tight range. So most of this improvement was within the tight range, which of course brings additional benefits, and no difference in time below range whatsoever. Here you can see the data. So the time in range, time in tight range, and time above range significantly improved, whereas no change or no cost, if you want to put it this way, in hypoglycemia with the use of CGM in this non-insulin treated population with type 2 diabetes. Importantly, they also check the PROMs. I believe this is super important because we always get this question back, yeah, you use CGM, but it's a huge burden to these people.
Don't come back out when you're ready. Today.
Okay. So it's a huge burden to these people. Yet the data doesn't support this attitude. As you can see, PROMs improved actually, better monitoring satisfaction, and no additional stress or burden was identified with the questionnaires that they used. This is a digital tracker and continuous monitoring study, and healthy adults and those with type 2, not treated with medications. This is the entire cohort improvement, a very simple study, not sophisticated. But please note, actually, the amount of time in range was close to 100% anyway, but it increased with the use of CGM, entire cohort, and this is the cohort with pre-diabetes. Of course, in this particular population, time in tight range would tell us much more than time in range. But again, we'll discuss this in more details tomorrow. Here, actually, is another way to looking at it. This is, you probably know Stu Harris from Canada. What he did is he checked whether the use of CGM in the population of non-insulin or insulin-treated individuals with type 2 diabetes speeds up the progression of therapy. And this is what happens. Actually, if you use CGM, the likelihood that you will get a better therapy sooner is considerably increased from 80 to 180%. In this particular cohort. And those that were used to use CGM prior to the initiation of the study were even more successful. This is why it says so this is why there are 4 curves. So experienced and naive cohort, naive to CGM. This is what is depicted. So higher increase in progression of the experienced cohort because they had some background information on what they do. Finally, we like to have meta-analysis to actually be sure that something really brings benefit. So, okay, the first one comes from the UK, Sam Seydoux and Pratik Chowdhury from Leicester composed this one. Here you have CGM versus, and you can see the outcome of these trials actually is significant. This is the iCGM versus the SMBG. You have a significant outcome here. Whereas, as you will see, actually, it's not only the glycemic benefit, it goes beyond. And here you have a second one that was published a month ago online I think in December. Again, same thing. So this is CGM, significant, both together, intermittently scanned and continuous with an A1C of minus 0.3. This is change in time in range. Please note, concomitant increase, very significant increase in time in range with a decrease in time below range in hypoglycemia. So again, this is a meta-analysis that helps us understand. This is the third one published in April, a good couple of weeks ago, online, I think in January or February, only non-insulin treated. So only non-insulin treated individuals. Again, an A1C decrease of 0.3%, an increase in time in range of 0.8% in this meta-analysis here. And of course, a time above range and time below range were also improved. So again, a concomitant improvement in glycemia without increasing, also even decreasing significantly the risk of hypoglycemia. And they measured the PROMs also, and this was a significant increase in this DTSQ, GMSS, and SDSCA were used in this particular meta-analysis here. This is adults, again, from Diabetologia. So the first one published online in February, now published I think in this issue. Again, so here you have CGM SMBG comparison. Here, interestingly enough, they didn't show for intermittently scanned because of one big study, but then altogether was significant. And what's good is that they have non-insulin treated group, and it's exactly the same. So 0.3% decrease, that was highly significant. And it is a concomitant increase in time in range and decrease in time below range. So basically, you have 4 different meta-analyses published in the last maybe 4 months that show you the same. So in non-insulin treated individuals with type 2 diabetes, you have an improvement in glycemia, improvement in time in range with a concomitant improvement in hypoglycemia. So that's why sometimes also the question is, can technology be used in individuals that are older? And I really love this commentary published in Diabetes Care because they say they even respond better. And interestingly enough, whatever population analysis we do, population above the age of 60 usually performs best with technology. Don't ask me why, but this is the outcomes also for the closed loop in type 1. So I believe, the older individuals may particularly benefit from the use of this technology. This is also a statement that I like. So CGM should be made ready. It's by the kind of a best of in the United States diabetologists. CGM should be made readily available to all individuals with diabetes. So we should not discriminate glucose based on the type of diabetes that this hyperglycemia is caused. And please note, payers and policymakers need to catch up. And finally, we have to catch up actually to provide better evidence so that individuals with diabetes should actually get what they need. Just a glimpse into the gestational diabetes, which is a subgroup of non-insulin treated diabetes, in most cases non-insulin treated diabetes. This is a interesting study in the Lancet Regional Health, West Pacific Journal. They showed, obviously, you're not surprised that using CGM improved every hard outcome of pregnancy that you can imagine. And Helen Murphy, a guru of pregnancy and diabetes, said that basically CGM should be used in every individual pregnant and having hyperglycemia. There were several studies that were a bit difficult to understand published in the ICU, but this is an interesting study demonstrating that the mortality actually was associated with time in range. Please note that time in range of 80% actually had the reference mortality, and it went up considerably when the time in range dropped, up to 8-fold. So even in the ICU, this is the studies from China. A lot of individuals were in ICU and hyperglycemia, but I believe they did a correct analysis, and this is now a confirmation of smaller observational studies published previously from Europe. What is interesting is that they saw the switch from non-significance to significance at exactly time when they look time above range of 180. So the threshold of 180 as an important threshold was basically confirmed by this analysis in relation to mortality in the ICU. Another, interesting investigation published in JCM last month. This is people at risk for type 2 diabetes, so pre-diabetes population, using an app and an intermittently scanned CGM. A randomized trial, so CGM without any additional intervention at the beginning and at the end, or intervention with an app and with an intermittent use of CGM, as you can see below in this schematic presentation. It's a Japanese study, so they had this lovely, figures in the app just to show you for amusement. But this is the outcome. So very, very successful outcome. To my surprise, time below range went up, despite the fact they didn't use any medications in this study. The reason for this is that, and this is also important, healthy individuals have approximately 5% of time below 70. So, being all the way down to 63 is physiologic, is normal. And this is what you see when you actually investigate healthy population with CGM. And we'll discuss this tomorrow. This is just perhaps a hint that for a massive use of CGM, particularly on the primary care level, where most of the people, non-insulin treated people with type 2 diabetes actually are, it is perhaps important to have the help of artificial intelligence. This is just a study published in type 1, but the second one is now in press for the type 2 diabetes, demonstrating that basically an artificial intelligence can be as good as an endocrinologist. And this particular clinical decision support system was cleared by the FDA for type 1 and type 2 diabetes, and in some places in the United States is part of the EPIC. They are potential disadvantages of CGM. And perhaps the most obvious is skin reactions. And skin reactions are actually perhaps visible in as high as 1/3 of the individuals, as you can see here. So there are two studies, two relatively recent studies both published less than a year ago. This is a nice study, 850 people were included. So the skin reactions in 28% with CGM and 29%, so a little plus minus 30% in this population, more in type 1 because it's much more used in type 1, a little bit more in females, but low overall discontinuation. And this study, they discontinued in approximately 3% of all of the entire user population. So yes, skin reactions are a trouble. It helps to change sites. There are several ways to mitigate it. It also helps perhaps to change the brand of what you're using. But in most cases, this will not prevent, the majority of people will not stop using it. This is the second most important trouble is disparities in access. And here the differences are huge. So the affluent environments, actually, the penetration may be above 80%, whereas in less affluent environments, as you may imagine, this is very, very low. I love this study because it shows that whatever your background is, if you have access to this, it helps. As you can see here, they tested different, this is from the United States, so non-Hispanic whites, Hispanic, Spanish, non-Hispanic Black population, they all benefit the same as soon as they are able to actually use it, as soon as they get access. So I think one of the most important things is that we make sure everybody has access to this technology. We are less exposed to this in the European Union because of the universal public insurance system that reimburses CGM for individuals with type 2 diabetes or non-intensive therapy. But then I understand other environments may be different, and I believe it's an important task to actually diminish these disparities as much as we can. Another important question also is what people with diabetes believe. This is a survey that was performed by the Time in Range Coalition. I think a very important group from the United States. As you can see, 1,000 people with type 1, a good 1,000 people type 2 on insulin, and 1,200 on non-insulin treated. They all put the time in range as the number one priority they have. And it's interesting because people actually, for some reason, got used to this time in range. They can accept it. They never accepted A1C, you know, because who cares if 3 months back you didn't do well? You can't change this anyway. It's like, you know, going to confession, I sinned, fine. I mean, can you change it? Whereas when you see your time in range at midday, you still have, you know, some 10 hours to improve the same day and basically do a change. And when you see a food doesn't do you good, you change the food and, you know, you're successful. So this is perhaps the reason why people with diabetes can accept this metric and really use it efficiently. If you want a meta-analysis on the outcomes, this is the hypoglycemia fear survey, very significant improvement, of course, in fear survey in this particular study. Of course, one possible question is it cost effective? And we have data, so the initial data comes from the Kaiser Permanente study from California, and they investigated type 1 population, and of course, it was cost effective immediately because of the reduction of emergency department of hospitalizations, but they also investigated the initial type 2 population also on non-intensive therapy, and it was the same. So the event rate for emergency department and hospitalization significantly decreased with a concomitant improvement in outcomes, and this was considered to be immediately cost-effective by the authors of this analysis. But we have a large French study. France has a single identifier for each citizen in France that actually identifies you within the public healthcare system wherever you are. So you're trackable even if you move and travel France around, and it goes from your birth till you die, and they stopped it. And this was linked to the database of the Libre downloads. And they were able to show, this is the initial study, 74,000 individuals, type 1, type 2, a decrease in emergency events. And this decrease was almost 50% in type 1, and in the first year, 40% in type 2. And in the follow-up of 2 years, it was 50% in type 1 and 50% in all type 2. So this is a very significant decrease in acute complications. And interestingly enough, the attrition rate over 2 years was very low. Please know that there is above 85% people stayed on sensor if you follow them up for 2 years in France. They then made a sub-analysis on basal only, and the basal only, interestingly enough, was even more successful, 67% decrease in the acute events. And as was shown for the Canadian population, an increase in the usage of disease-modifying medications. So as soon as this population, so basal-only population, visualized their glycemia continuously, they got better therapy. And this is the above 65, is another, as I mentioned, interesting population because there were some concerns that people above 65 or whatever age cannot use successfully the technology, and it's completely the opposite. So they were as successful as anybody else, and the reduction after 2 years of the acute events was comparable to any other population, and the attrition rate over 2 years was even less than in all other people. So as I mentioned, they are more successful. Another analysis here, this is event reduction in non-intensive diabetes therapy that's coming from Canada. This is pre-acquisition, post-acquisition, so you can see a very significant decrease in acute events. This is inpatient or outpatient emergency, and this is all-cause hospitalization in this cohort of 10,000 individuals that were analyzed in this study. I'll just briefly touch why I believe this can be important. So this is an interesting study from Japan. So what they did is actually they checked people with They checked people with normoalbuminuria, microalbuminuria, and macroalbuminuria. As you can see here, glycemic markers were, of course, very, very similar. So A1C 7, 7.2, 7.1. It was different because of non-diabetes group. But in between the three, there is no difference whatsoever. Whereas the time in range differ for 15% per day. Just to let you know again that you cannot identify people at risk if you use only a surrogate marker of the mean. You need a more precise visualization of glycemia to identify people at higher risk. So here, actually, as you can see in model 1, when they modeled it, the prediction power of different measures of glycemia, A1C with correction for cofactors lost significance completely and could not predict the micro and microalbuminuria, whereas GMI did. GMI is the A1C calculated from CGM, or time in range did, or time above range. So basically, again, the same message as shown so many times. Time in tight range is a topic of my tomorrow language. I'll just touch it briefly. So when you use a very potent medication, like in this case, tirzepatide, as the only medication, so no insulin, insulin was the comparator, you see that people may actually reach, this is at 1 year of therapy, time in range of above 90%. So it's hard to discriminate what's happening. And for this, actually, perhaps time in tight range is a better marker. And here you have it. It's a strike of luck that this study from 4 or 5 years ago now used time in tight range as the primary outcome. And yes, time in tight range was 73%. It's very high. I will show tomorrow the time in tight range depends on the amount of hypoglycemia. And here there was 0 hypoglycemia because tirzepatide doesn't do it. And despite this fact, actually, the time in tight range was above 70% and with a very high ratio, and we'll discuss this ratio tomorrow. Another proof of this concept is the Maastricht study recalculation. Please note that this population had a time in range in between 94 and 100%. 100% time in range, which is 70 to 180. It's not normal glycemia, right? Despite this fact, actually, there was a very clear correlation with time in range and carotid femoral pulse wave velocity, which is the proxy of the cardiovascular damage. So despite the fact that these people were above 90% of time in range, still it was actually related to the cardiovascular proxy marker. So the time in tight range seems to be a very important, obviously, if also healthy people without diabetes have cardiovascular risk, then the time in tight range, perhaps it's something that is coming. Interestingly enough, and to our surprise, the FDA actually believes that this is the most important outcome, and they are helping us introduce this into clinical practice. Another recalculation, this time devotee study by Rich Bergenstahl. So he used the devotee data, and he looked at MACE, severe hypoglycemic episodes, and microvascular events, and he see no significant prediction with the A1C. When he used derived time in range, please note that time in range above 70 is significantly predictive MACE, severe hypo, and microvascular events. Just to show you, a same message from a different angle. He also showed that at 70% of time in range, the slopes of this complication starts to level off. So perhaps the 70% is a good initial target. But for this part of, as I mentioned previously, perhaps time in tight range would be a better marker. This is drug-naive Japanese individuals with type 2 diabetes. And very interesting, please note, so I gave you the table. So this is actually GMI, calculated A1C of 6.3. This is GMI between 6.3 and 7, and this is above 7. And please note that the marker that changes most is actually the time in tight range. So this person has the time in range of, I calculated here the ratios for you. So the initial ratio is almost 1. So if you're at a very good control, they're very similar. But then the time, this is the change in time in tight range, this is the change in time in range. As you can see, the highest loss when you progress in diabetes is in tight range. And this is why also the initial change is actually causes damage, mild cognitive impairment, and cardiovascular risk, as discussed previously. So here the change is 1.8 times difference and then 1.2 times difference. Most initial loss is loss in time in tight range. By the strike of luck, when we did this consensus for the clinical trials with medicines in the use of CGM, we added time in tight range. At that time, we didn't know it was important, actually, and by, as I said, by a stroke of luck, this seems now to be the most important parameter, because it's closest to physiology, I guess. We just published this perspective, and in this perspective, we already state quite firmly that all people with type diabetes actually should use CGM regardless of what therapy they use, and they should use it mostly not to prevent hypoglycemia, because this is less and less of an issue, but to really maintain time in range and time in tight range so that we can finally prevent cardiovascular damage and dementia in this population. I won't go into details. We ask for evidence generation to be more able to get this reimbursement in different environments, and we also state unmet needs in this Nature review paper, if you were interested to read it. We also propose an integrated personalized care environment, actually, that would link all that we have now in our hands. So innovative medications, technology, and also, of course, artificial intelligence to actually work with this large amount of data to help us understand who's at higher risk, who's doing well, and basically tailor, personalize the approach to these people. Allow me to propose a couple of conclusions to you. So first, please, it's high glucose that does the damage. So this is the real, if you want, enemy that we have to address. CGM helps in all individuals with the limitations that we know, but it does help randomized controlled and large observational studies and meta-analysis proof data. Time in range and time in tight range are strongly correlated in the usual range, but, and this is a teaser for tomorrow, there are additional benefits for hard outcomes if we use time in tight range as an outcome. You're all invited to the ATTD in Amsterdam next year. Many ongoing studies will be presented there for the first time. And I heard people saying Amsterdam's not the worst city in the world either. So perhaps you may want to join us there. With this, I thank you very much for your attention. This is my team. They have to work while I speak. Thank you very much.
Thank you, Dr. Battelino. I'm not sure if there are any questions on the chat or here, but I do have a question. You show compelling evidence about the effects of hyperglycemia, and we see even less now, the frequency of hypoglycemia in people with CGM. But the question is more about hypoglycemia and awareness. So is there any, or can you expand on how you can use perhaps CGM to predict patients that will develop hypoglycemia and awareness?
So Pratik led a study in Europe that's called HypoCompass. And he actually, it's very interesting, was unable to give specific predictors of hypoglycemia and awareness. Number one. Number two, it takes more time to actually become aware again that we thought in type 2 diabetes. It's quite a persistent condition. But interestingly enough, when he identified those, and this is, I'm not sure this is published, he just had a lecture recently that I attended. The outcomes with people using CGM, with people with hypoglycemia unawareness and those that were aware were not different. So hypo-unaware people using CGM actually did not have more severe hypos as those that were hypo-aware. So his suggestion was that perhaps hypo-unawareness is not that dangerous, that detrimental, providing that you use technology, providing that you use CGM, because it would alert you and you would be able to react.
Regarding the group of patients with different hemoglobins turnover, like end-stage renal disease, are there any comparative studies that assess, which way to follow them, predict better outcomes?
Thank you very much. Yes, it's a very recent study, actually, We just discussed this yesterday, published, and we know that A1C doesn't help in if you have end-stage renal, but also below 60, actually, already it starts to fail. And to the contrary, the CGM actually gives you the same information. So it is suggested by people that are involved in renal failure and diabetes that CGM actually would CGM-derived metrics would replace A1C also in this population. And there is evidence to support this. The accuracy, we just saw the data yesterday. The MART in eGFR below, so in between 15 and 60 was around 14. So good enough.
Any questions on the chat? No? I do have more futuristic questions. So what do you see in the future coming for diabetes and technology? What advances and how you maybe see diabetes treatment in 10 or 15 years?
As you know, as the famous British said, it's hard to predict, particularly the future, isn't it? So what I believe is that, this connected care will become more available and more prevalent. What happens in our center is that, almost everybody uploads their devices at home, some of them continuously. So we have this information all the time. And basically, if you have an artificial intelligence system that identifies people in trouble, you can have, when you come to your office in the morning, a list of people in trouble at home. And, you can have a nurse practitioner contact them and says, you know what, this is what we see. Why don't you, do this and that? So very likely technology will be inevitable in many areas of diabetes, including glucose monitoring. And with the use of novel medications in type 2, the focus, because you can't do hypoglycemia with tirzepatide, can you? So this will become a non-issue, I hope. And we will really focus on high glucose and try to maintain time in tight range meticulously so that people actually will be without the consequences that we face now. This is, I hope, my vision.
And devices?
I think devices are reasonable at the moment. They're just too expensive. So I expect that we'll get competition very soon. And very likely, somebody will find a way to put a non-invasive sensor somewhere, so everybody will be somehow, monitored if you want. We will discuss tomorrow large studies. So hundreds of people without diabetes monitored with CGM. And you'll see it's super interesting. So very likely, not only people with diabetes, but also people in sport, people in stressed conditions, or, people getting older, which happen to people from time to time, will wear CGM.
Dr. Galindo and Dr. Goldberg.
Thank you. Thank you for the lecture. And I'm sorry, I'm going to be a little bit, this is an area of work for me. So compelling evidence for type 1, compelling evidence for type 2. So do we need to use CGM in people with no diabetes or pre-diabetes? And if we do, how do we convince the payers that it makes sense? Very, very quickly, we only have a couple of minutes.
Yeah, thank you for this question. So what's happening is that in Japan, in June of this year, they will have an indication of behavioral modification use of CGM for the general population. I was amazed. Why Japan, the first country, of all? They will have a small co-payment for it, but it will be largely reimbursed. And the second country, I understand, that will do the same is France. So what's happening is that payers understand that preventing this major trouble, like dementia, is super expensive for public systems, super expensive in our environment. It is much better to invest in very early detection and prevention of hyperglycemia. So it will be a cost-effectiveness decision, basically, that will drive, I think, a very early usage of glucose visualization. Okay, so you see, so perfect.
Dr. Goldberg, do you want to unmute and ask your question?
Yes, thank you very much for this presentation. I enjoyed it. And I must say, I agree with you completely about the importance of a glucocentric point of view. And to take nothing away from that, however, I'd like to ask you about your views on the extensive literature on non-glucose mediated complications, those related to obesity and those related to insulin resistance, unrelated to obesity. How do you add that into your thinking about preventing these complications?
Thank you very much for this question. I fully acknowledge it. I agree with you. I selected to be glucocentric, but I understand, obviously, I think we are a bit lucky. You know, if I remember 10 or if you want 15 years back, to be pessimistic, we didn't have anything to treat obesity or type 2 diabetes. It was super boring. It was sulfonylureas, perhaps a couple of medications that came and, you know, were not either dangerous or not very successful. Nothing successful or safe for obesity. We are super lucky now because with a single thing, actually, we reduce weight. We, you know, improve glycemia very, very significantly. We improve lipids. They're cardioprotective, they're renal protective. So what do you want? I mean, I think we are lucky at the moment. And if you ask me if I believe that obesity alone and insulin resistance is disease, the reply is yes. And we should treat it. We shouldn't say people, you know, just eat less and exercise more, because some of them can't and are severely sick. So I think we should treat it early.
Thank you.
In the last minute, Dr. Baidal, do you want to unmute and ask your question?
Yes, absolutely, Dr. Battelino. Thank you so much. I did join a little bit late, so you may have already covered some of this, but I was wondering, as it is clearly from the data you have shown, that time in tight range will ultimately become an endpoint for diabetes management. Are there data in type 1 diabetes? I think I saw a lot of the data in type 2 and some on basal insulin, but clearly achieving time in target range on the background of intensive diabetes management, as it is right now, is already challenging to achieve that more than 70% time in range. And clearly, time in tight range may be much more challenging. But again, your view regarding that and the challenges to be able to, you know, achieve that type of controls in patients with type 1 diabetes, if indeed these endpoints are to be followed because they have a reduction in mortality, cardiovascular in particular, and brain damage.
Thank you very much. It's a very important question. So if I may rephrase it a little bit, are we adding additional burden to people, you know, by saying, you know, okay, you have to be time in range. Now, all of a sudden, we want time in tight range. So what's wrong with us? And I actually initially thought so. But then, you know, the Swedish people actually show the opposite. So if you go to the public webpage of the Swedish type 1 public registry, it's open to everybody. They only show time in tight range. They actually excluded time in range as a public marker. And they are much more successful than anybody actually anticipated. If I go back to an old Hvidore study in Europe that was replicated recently in the SWEDE database, the more ambitious the target of a center, the better the outcome. So perhaps, just perhaps, we are over-concerned or too, you know, paternalistic about our people with type 1 diabetes. It looks like they can do much better than perhaps we believe. And the outcomes in Sweden are really good. So we decided also to change this in my center, and we started to discuss time in tight range. And surprisingly, people, you know, are not really unhappy with it. They have a new goal that's very close, that doesn't need any additional education, or, you know, they understand it's closer to normal. It just depends where we decide to put the target. You know, if the target is impossibly high, I agree with you, it's wrong. It's the wrong approach, but it's an option they may want to take, actually, if they do well. If they don't do well, whatever we have should be sufficient at the moment. This is how I try to see it. So as an opportunity, actually, to improve, not as an additional burden. And of course, time in tight range in type 1 is only related if you use closed loop. So we do not discuss it outside the closed loop. But you have to understand that in the European Union, around 60 to 80% now of individuals with type 1 are treated with a closed loop.
Thank you.
Thank you so much for a wonderful talk. For those of you online, please note that in the chat, the CME and MOC credits are available in that link, and for those live, the QR code. So thank you very much.